Hello, good morning, everyone. Can everybody hear me well? Okay. Good morning, distinguished keynote speaker, respected speaker, poster presentation, honorary delegates, and estimate participants join us from around the world. It is a great honor and privilege to warmly welcome you all of the prestigious Joint Emirates virtual conference. On behalf of the organization committed, I extend our sincere appreciation to each of you for taking the time to be part of this significant global gathering. Today represent more than just the common sense of conference. It makes the beginning of the dynamic and collaborative platform where knowledge, innovation, and expertise coverage. This event embodies the true spirit of international collaboration, uniting professionals from diverse fields such as nursing, patient safety, cardiology, dentistry, and the broader healthcare community. Together, we aim to exchange value insights, showcase cutting edges research, and discuss particular advancements that will contribute to improve clinical outcomes, enhancing patient care, and shaping the future of global healthcare. I am Dr. Claudia Arias, and this is my pleasure to serve as a chairperson for today. I look forward to an engaging, inspire, inspire, and highly productive day together. Utilitarian Conference Gathering is a leading global platform dedicated to organizing high-quality professional meeting, conference, workshop, and symposiums with a strong focus of the medical, clinical, healthcare, life science, and pharmaceutical fields. Multilateral conference gathering effectively bridge the gap between academic and industry through innovation, collaboration, and excellence. With a global research 24/7 support and highly committed organizing team, utilitarian conference gathering ensure that every event is impactful, well-structured, and tailored to meet the evolving needs of these participants. On behalf of utilitarian conference gathering, I extend my heartfelt gratitude to our organization committed, distinguished speakers, and all participants who have contributed to making this gathering a success. Together, we are driving progress and shaping the future of healthcare. Ladies and gentlemen, first, our first speaker is Dr. Naved Kaur, Department of Periodontics, join us from India. She will present on 3D dimension printing tools for futuristic dentistry. Kindly join me in welcome her to the stage.
A very good morning to Dr. Claudia.
Good morning. Can you
So,
share presentation, please?
yeah, I'm showing you. Just wait for 5 minutes. I just show my slides here. Yeah, I hope my slides are visible right now.
Yes, thank you so much.
Okay, so shall I start?
Yes, please go ahead.
Yeah. A very good morning to everyone who are present here in the 5th International Dental Advanced Dentistry Oral Health Conference 2026. And thank you so much for giving me an opportunity to become a speaker to share my knowledge and opinion on the latest technology. So, today I'm going to present a topic on three-dimensional printing as a futuristic tool in dentistry. So, myself, Dr. Navneet Kaur from Baba Farid Health University of Health Sciences, working as an associate professor in the National Dental College and Hospital, Dehradun, Punjab, India. So, let's begin with the understanding what is three-dimensional printing tool and how it is transforming the modern dentistry. So, three-dimensional printing, it is an additive manufacturing, refers to the fabrication of three-dimensional structures from the digital model using a layer-by-layer approach. This additive manufacturing is the terminology given by the American Society of Testing the Materials to make an object from three-dimensional models data, usually layer upon layer. So there are various synonyms used for this 3D printing tool as an additive manufacturing with the name of a repeat prototyping or the desktop manufacturing or maybe the digital prototyping. So each one of these terminology has a distinct meaning and are interrelated with each other. In dentistry, it is transforming in the diagnostic aspect, in the treatment planning, as well as the clinical outcome in terms of the patient's aspect. It also enables the development of the patient specific models, guides, and prosthetic solutions. This technology significantly improves precision, efficiency, and overall clinical outcome. Coming to the historical aspect of this 3D tool. So in the eras of 1980s, this Charles W. Hull, who developed the stereolithographic technique as a file format and is considered the father of this three-dimensional printing tool. He is marked the beginning of this rapid prototyping. So I am showing you here the timeline of this three-dimensional printing tool in the era of 2012, which is the recent one. There was the first three-dimensional printing with the placement of an immediate dental implant into the patient's mouth. But in the 2020, again, recently, the dental ceramics 3D printing system was applied to fabricate the zirconia mandibular molar crown. So now what is three-dimensional? As I already discussed that it is an additive approach. It means there is an addition of the material into layer by layer. So it is a digital workflow on the basis of the specific design used as a blueprint. So in the first step, what is going to be done in the three-dimensional printing technique? There is a collection of the data. The raw data is going to be collected through the digital scanner. Then what is going to be happen for the collection of that data, that gathered data is used to build an object using the CAD manufacturing. That CAD manufacturing is already being attached with that the computer software. And after that, that digital data processing was there through the CAD software. So these are the basic three steps you can say in the form of a processing for this three-dimensional printing technique. Now, coming to the general principles of three-dimensional printing tool. So the first tool is the modeling in the form of a principle of this three-dimensional printing. In the modeling, what is going to be happen again? The collection of the raw data that is transferred into the computer software for the analysis, and it makes the final version of the replica of an object. So basically, the collection of the data till the expression of the computer design through the various softwares is considered the modeling step. Second step is the printing, where the formatting model that is going to be converted into the G code file, or there may be an STL language. The STL language means the surface tessellation language, that the sections of the replica of an object, they are going to be converted into the layer by layers. So there are various other programs instead of this G code file or the STL file as a computer software. They are also commercially available with the name of a Cura or Slice 3CR. So this G code file are followed by the instructions of the printer to lay down the successive layers of the material in order to build the three-dimensional replica. Now coming to the what is the advantage of this thing? So it is going to reduce the time of the manufacturing of the three-dimensional object. That is, from days to few hours. Again, it will depends upon how the software or how which type of a software you are going to be used, either the Cura, either the slice CR, or either the G code file you are going to use in the printing step. But in the last step, that is the finishing step, is there. After the printing of the oversized model which is going to be produced, that is going to be finished off in this step, that is a removal of the excessive layer of the material that is going to be deposited during the printing step. So also the another advantage of this finishing step is that there is a surface roughness that is also going to be removed in this step. It means the polishing step is there, the finishing step is the last step as a principle of three-dimensional printing tool. So this is a diagrammatic representation I'm showing you here. That is the three-dimensional object is how it is formed through the computer software. So again, in the first step, here there is a generation of this CAD software in the computer software, and then the STL file is going to convert into the G code file. Here there is a slicing of the object, slicing of each layer of the layer of the object is going to be transformed into the computer software, and there is a simulation of this three-dimensional printing in a CAD-CAM environment. And after the three-dimensional printing CAD-CAM environment, there is a prototype is going to be fabricated and final version of this three-dimensional printing model. So basically this is a diagrammatic representation how the modeling process, how the printing process, or how the finishing process is going to fabricate the three-dimensional object for the use or for the application of the dental procedures. So coming to the techniques of the three-dimensional printing technique, so there are various techniques used for this three-dimensional printing technology. The first technique is the FDM technique, that is a fused deposition modeling technique. Most common material is going to be used is the PLA material, ABS, or the nylon. ABS basically the material is acrylonitrile butyrostyrene, or PLA model is a polycaprolactone material or the nylon. So these are the most common material used for this FDM technique. So what is going to happen in this technique? The small beads of the thermoplastic material, they are released from the nozzle to construct the model. So this material hardens immediately within a 1 second of the production of this three-dimensional object. So this material have a difference in the strength aspect, in the flexibility, in the biocompatibility with the oral tissues, that making the suitable for the different kinds of the dental procedures. So this FDM technique also allows the printing of the complex anatomical models without an excessive amount of the material, especially in case of the complex mandibular. Edentulous mandibular is going to be fabricated through this technique. So FDM technique is one of the technique most commonly used for the various dental procedures. This is the second technique, that is a SLA technique, that is a stereolithographic technique. So again, the most common material used in this SLA technique is a liquid polymer and the resin. So here the UV light is going to cure the resin or the polymer, and UV light create the parts in the form of a layer. So each and every layer here in the light beam traces the cross section of the part pattern on the surface of the liquid resin. So the exposure of this UV light solidifies the each layer and each pattern of that three-dimensional object which is going to be traced on the resins and joined to the lower layer. So what is the major advantage of this SLA technique? It offers a high precision with a minimal layer thickness. And the post-processing steps that includes the UV curing, removal of the supporting structures when it is already going to be immersed in a chemical bath or the material. So this technique is most commonly used for producing the dental models, for the fabrication of the surgical guides, for the obturators, for the stents, and the duplication of the prosthesis. But again, this technique has a disadvantage. So there might be a shortage of the biocompatible resins. So that is the major advantage. No doubt there are various advantages, but disadvantages also there. Only the shortage of the material which is going to be used in the SLA technique. The third technique is the SLA technique, that is the selective laser sintering technique. So here again the laser beam is going to hit the powder. So powder particles are going to be used, or the resin particle in the form of a polymer, they are going to be used and fused together with each other layer by layer to form an object. So the post-processing steps in this technique is the dusting and the scanning. So this method is useful for the strong and durable dental components. So SLS is utilized in the fabrication the anatomical study models, slicing and the drilling of the guides, dental models, and additionally in case of the engineering prototypes. So basically all the anatomical study models, all the drilling guides that is used in case of a dental implantology, that is also used in case of an oral surgical departments like the slicing or the drilling guides, they are used or they are going to use to fabricate the surgical guide with this technique, the SLS technique. So this is again the another technique, that is the ML, material binding technique. So here there are two types of the printer. One is a thermal inkjet printer, second one is a powder binder printer. So the most common material used in both type of printer is a gypsum powder bed that is further incorporated into the water as well as in the starch. So in the thermal inkjet printer, what is going to be happen in a non-contact approach, it makes the thermal electromagnetic or the piezoelectric era to deposit the tiny droplets of the ink. So this is an inkjet nodal. So this is an jet nodal is there. So here droplet by drop, the ink nodal give you the drops of the ink, and here there is a layer by layer deposition of the material to form the object or to fabricate the object in this technique. So the volume of this nozzle is around 10 to 150 picoliter. It is in the picoliter. So this volume is 10 to 150 picoliter. So particularly this type of a printer is used in case of the tissue engineering techniques as well as for the regenerative medicines. In the second printer, what is going to be happened? The liquid droplets, they are made to infiltrate a uniform and a single layer of the powder, one after the other, and the powder matrix drops incrementally again in the form of a liquid droplets to construct the layers of the newer object. Coming to the processing of this three-dimensional technique, where there is a first step, the data acquisition is there. That is through the again the CAD package, 3D scanner, or the plain digital camera is there. Then that data acquisition, that is in the form of to convert the STL file conversion. STL file conversion is already being attached with the computer software, and there may be a collection of that material into the form of a triangles, just like a puzzle of an object. So here the post-processing step is there, the curing, polishing, cleaning, or the sterilization before the three-dimensional printing to become an accurate product that is going to be formed. So these are the basic steps for the processing of this three-dimensional printing technique. So these are the various materials which I have already discussed in the previous slides for the technique. The plastic filaments are there, nylon is there, metals are there, or even the poly PLA material, or there may be the gypsum powder material is there. So these are the various materials that is going to be used for the printing of the three-dimensional object. So this is an overview of the material with their properties and their different uses in the dentistry. For example, for the fabrication of the denture or the crowns, like the cobalt chrome or the zirconia metal is going to be used, and the technique is used is the SLS technique, the thermal inkjet printing technique, or there may be the FDM technique, which is a fused deposition modeling technique. For example, for the fabrication of the dental implants, titanium is most commonly used metal that is most commonly biocompatible with the oral tissues. It is a bio-inert material. But this implants, the fabrication of the implants, they are going to be formed through the SLS technique, that is through the direct metal deposition technique, or that is also with the photopolymerization, or there may be a inkjet printers. They are going to fabricate the bio-inert material to place the dental implants. So coming to the advantages of this new dimensional, three-dimensional technique in the dentistry. So firstly, it provides the high precision and the accuracy, which helps to create an exact replica of the patient anatomy and improves the treatment outcome. Secondly, it also allows the customization and the patient-specific treatment. It means the dental appliances or the placement of a dental implant can be tailored in case of an individual patient's. It also reduces the treatment time as well as the laboratory procedures. For example, for the fabrication of the denture, there is a lots and lots of lab work is there. But where with the help of this three-dimensional technique, it allows the workflow more faster and in a more efficient way. It also reduces the human errors as well as it is a cost effective only in case of a long runs for the bulk production of the material. It also serves as an excellent training and educational tool for the dental students and professionals. So overall, basically, this three-dimensional printing tool enhances the efficiency, accuracy, and the quality of the dental care, and it is one of the highly valuable advancements in the modern dentistry. There is a no doubt it have n number of advantages, but still it also have a limitations. Certain types of the limitations are also existing with the three-dimensional printing tools. So firstly, again, the high initial cost, but the cost is most effective only in case of a long run. Secondly, it is a time consuming process only in case of the fabrication of the complex anatomical structure or the complex fabrication of the surgical guides or the stents. That is only in case of a time consuming. Otherwise, it is a very good material or very good tool for the fabrication of the objects for operating the dental procedures. Third limitation, that is one of the, there is a limited range of the material, might be the biocompatible material, that may be a shortage of that material which is suitable for all types of the dental applications. So that is one of the limitations. Another limitations, there might be issues in case of the consistency and the quality control, especially in the repeated productions. Also, there may be a technical expertise and the training is required, that lab technician or any kind of an expertise that is required to operate with the minimal or maintain this technology more effectively, especially in the dental procedures. So these are the various limitations. Now, coming to the clinical application, so let's talk one by one. It is going to be used in the various aspects of the dental procedures. So firstly, it is used to fabricate the digital denture, and their processing is through the additive manufacturing, not through the formative or subtractive. So, conventional dentures, they are already going to be formed through the formative manufacturing, where the alginate impression is going to be taken, then it is going to send to the lab area for the various aspect or the various steps to fabricate the denture, to cure the denture. But with the help of this three-dimensional technique, it is an additive approach. Here the three-dimensional printer is used as well as the intraoral scanner is used to take the impression. So digital denture processing is to be done through the additive manufacturing technique. So this is the advantages for the prosthodontics aspect. Secondly, it is also used for the production or fabrication of the temporary crown as well as the resin pattern. Also, it is going to form the printed models, three-dimensional printed models, as well as the temporary crown, the resin pattern for the casting. So these resin pattern or the casting, they're going to form through the SLS technique or maybe the FDM technique or through the inkjet printing technique. So it helps to reduce the error as well as it helps to enhance the accuracy in the material or at the precise detail at the anatomical aspect. So these are the various uses in the prosthodontics aspect. In case of orthodontics, so aligners, that is in the today's dentistry most commonly used in case of the malocclusion area. So aligners, they are usually built through the CAD/CAM technology. That is one of the advantage. That is, you can say it is one of the advanced detail in the malocclusion or for the treatment of the maloccluded area. Either the class 1 malocclusion is there, 2 is there, or the 3 is there. Even for the advanced surgical procedure in ortho, the orthognathic surgeries, three-dimensional printed models, they are reconstructed through the CBCT scan. So these are the major usage in case of the malaligned teeth or in case of the advanced surgical procedure, the major use of this three-dimensional printing tool. Now, this patient on the right side I'm going to show you here is the first patient who was treated in the year of 1999 with an implant supported bridge work using the 3D printing technology. And on the left side, so this is on the left side, this is the printing technology, basically the frontal view of the medical model. So and this model is going already fabricated through the FDM technology, that is the fused dimensional modeling technique is going to used for the surgical guide or the surgical stent to form the three-dimensional object. So in case of an implantology, most commonly used implantology area. So in the implantology, this three-dimensional aspect or the tool is going to fabricate the surgical guide. This is for the zygomatic implant insertion. This third picture is the surgical guide, fabrication of the surgical guide through the three-dimensional printing tool through the computer software. So this is the virtual plan for the treatment for the patient for the formation for the placement of the zygomatic implant into this area on the maxillary area, especially in the maxillary area. So this is the already the surgical aspect of the flap is already going to raise in the maxillary area. So here the multiple implants are going to play already placed in the OPG, that is going to I am the post operative picture of this OPG showing with the placement of the multiple implants. So after planning this digital surgical guide, so CAD software, CAM software, the computer software, they are all used to form the, in a more accurate way, in a more precise way, the formation of the surgical guide that is going to place with an exact angulation, with an exact dimension, especially in case of the zygomatic implant insertion. So this surgical guide is formed through the SLA technology with a high accuracy. So it also enables, this SLS technique enables the production of the patient specific implant, improving the surgical outcome. So it is also used in case of the patient-specific implant manufacturing technique. Again, this is the mandibular jaw area. This is a surgical stent or the guide, and this is an OPG showing the placement of the dental implant. So these are the placement of the edentulous space in the mandibular area. So this is a surgical guide. So that is this surgical guide is going to operate through the STL file in the computer software with a higher accuracy, and implant was placed in the mandibular jaw. So this is a post-operative pictures of the OPG showing the placement of the multiple implants with the permanent crown placement. In case of, it is also, this 3D printing tool is also used in case of the alveolar ridge preservation through the surgical guide, through the FDM scaffold specially designed to match the anatomical dimension in case of the extraction socket. So that is one of the specialty in the oral surgery where the extraction socket is there. So for the preservation of the alveolar ridge, that is a important parameter to place a dental implant in the future, as well as the immediate placement of a dental implant. So we have to preserve the alveolar ridge, and the surgical guide is going to fabricate through the FDM technology. So in the reconstruction plates using the SLE model. So again, this is the surgical guide here. So this is the pre-bending plate for the mandibular reconstruction prior to the resection of the symphysis area. So this is an OPG showing the pre-bending of this prefabricated plate in the mandibular reconstruction area. In the reconstruction plates, basically these are the all advanced surgeries right now. In case of the trauma, in case of the fracture, in case of, you can say, the carcinoma cases, in case of the tumor cases, this surgical guide, surgical stents, or the placement of this pre-bending plates, they are most commonly used in all these cases. So in case of the another case, I'm showing here the TMJ reconstruction surgery in oncology section. So in case of the tumor cases, it is most commonly used to with a precise detail with a higher accuracy. So again, this is the surgical guide. So again, surgical guide is going to be fabricated through the three-dimensional printing tool, and it is going to place here in the operated area, and this is the post-operative picture. So basically, this three-dimensional printing tool, either in case of the mandibular large defect, in case of the tumor resection, or in case of the complex facial symmetry. So this surgery was planned through the fabrication of the surgical guide. Surgical guide is a tool that is give you a new direction where it is going to be placed, where it is going to be resected, that which area is going to be resected and which area is going to be preserved. So this dimensional technology, three-dimensional technology, is most important, and it is very useful in the advanced dental surgical procedures. So this is another case of the tumor resection. Again, this is the surgical guide. It will guide to help to place the dental implant into the edentulous area. So this is again the surgical guide, and it will help to place this dental implants into the surgical area where it is going to be placed with a precise detail. So in case of the fibrous dysplasia, for the drilling of the guide, so this is the virtual aspect. So this is the virtual aspect of the surgical planning of the three-dimensional printing tool, and this is the printed drill guide here. It is already going to be placed when the fibrous dysplasia tumor like it is going to be removed during the surgical aspect. So it is in periodontology most commonly used in case of the periodontal osseous defect. So this is the defect showing in the mandibular area at the baseline area. So this is the CBCT model. CBCT model here it is a defect. The periosseous the defect is there. So this blue area basically, this is the polycaprolacton scaffold. This is the three-dimensional printed scaffold is there. So here there is a defect. Where the defect is there, this polycaprolacton material as a scaffold is going to place to cover or to regenerate the area into the periodontal ligament, into the osseous structure, into the alveolar bone. So this is scaffold. This is how the scaffold is going to place here. After raising the periodontal flap in the osseous defect area, after the removal of the granulation tissue, this scaffold is going to be placed and the suture to be done. So after this is the post-operative picture of the 6 months and the 1 year. So 1 year there is a reduction in the periodontal ligament, this periodontal probing pocket depth as well as the gain in the clinical attachment level. So this is the case for the peri-osseous defect where the three-dimensional printing tool can be used as a scaffold, as a matrix. So this is one of my article that is already been published as a future dental devices three-dimensional printing approach in a dentistry in the 2021. So again, this is a literature evidence. They are showing the placement of the three-dimensional printing scaffold into the osseous defect with a different material at the different time period of the study. So I am here highlighted one of the study in the 2015. So this three-dimensional printing tool was used in case of the periodontitis as a clinical case in the canine area, and the time period was 13 months. So this case basically concluded that there was a gain of a 3 millimeter in the clinical attachment level, but after the 13 months there was an again exposure of the recession area. So here I will say my opinion for this three-dimensional printing tool is that this technique has a various and a number of advantages, but no doubt it also have the various disadvantages in the form of limitations. So this technique have both the pros and the cons when it is going to be used as a clinically into the clinical cases, especially in case of the periodontitis, especially in case of the stage 2, 3 or grade A or B periodontitis or the recession cases especially. So these are the various commercially available top 3D printer brands for dental practices that is commercially available, and companies are going to form these three-dimensional printing tool with the name of this Accurata, Asica, Riton, Alico. So all these three-dimensional printing tools, they are used most commonly in the major dental practice. So before concluding, I will say the three-dimensional printing technique gaining the more popularity in terms of the tissue engineering architecture as well as the fiber this guiding scaffold design or for manufacturing the potential application in the future. So this, for example, in case of the periodontology, the osseous defects are the most common, whether it is a shallow defect, whether it is a deep defect. So clinically we will examine the patient that there is a defect in the maxilla or in the mandibular area. We will go ahead with the radiographic examination, the CBCT, or that might be an OPG or RBG is there, that is going to show you that this defect is there, how much defect is there, how much details of the defect is there, how much depth or the length of the defect is there. That is the first step. After gathering all the data, what is going to be done? That is that gathered data is going to be attached with the computer software. So computer software will generate the STL file in the form of a G code. Then what this G code file will do, it will do the tissue interface determination as well as the architecture design. Architecture design is only just for the formation of the fabrication of the three-dimensional object, that how much width, how much length or how much depth it is going to be placed, that STL file or the G code file will decide based on the depth or the based on the defect which is going, whether it is a deep or whether it is a shallow. Then after designing the object, there will be another evaluation with the help of the rapid prototyping process. So evaluation is going to be done through the computer software again. So basically all this digital data is into the computer software. Then after that, for fabrication of the object into the as a three-dimensional object, it is going to be ready to be placed into the defect area. Into the defect area, whether that defect area is in the form of a scaffold or in the form of a surgical guide that will guide us to place that material, to place that biocompatible inert area, or to place the scaffold into the periodontal osseous defect. So this technology basically allows the better pre-surgical planning using the three-dimensional imaging, improving the accuracy and predictability of the outcome. So it plays a crucial role in managing the complex cases in both the surgical safety and the patient satisfaction. So to conclude, three-dimensional printing is a rapidly transforming modern dentistry. It enables precise, customized, patient-specific treatment. It improves efficiency, accuracy, and the clinical outcome of the patient. It also provides an effective educational tool for both dental practitioners and for dental students. So therefore, it represents the future of the advanced dental care. So these are the references, and thank you for your attention.
Thank you so much for that kind of presentation. I really appreciate that you share your knowledge with us. If you don't mind, I have a couple of questions to ask you.
Yeah, for sure.
I want to know what are the main application of the 3D printer in modern dentistry? Because you explain about implants, you
Yeah.
explain a couple of types, but I would like to know the modern dentistry.
Uh, Basically, the major advantage of this 3D printing tool is that it is going to guide us the complex surgical anatomy of the facial area. As a surgical guide, it is most commonly used. Also, it is an educational tool for the dental practitioners as well as for the dental students at the institutional area. So these are the major two advantages at the institutional area as well as at the practice area for the surgical guide to treat the complex cases. These are the two major advantages.
Okay, that answered my second question, like
Yeah.
how is the 3D printed transforming traditional dental procedure? I'm also a dentist, and
Okay.
I know that a lot of dental students they learn a lot with the 3D printer.
Yeah.
And I have just a last question. What type of material are commonly used in a dental 3D printer?
Most common material that is in the form of either the metal, that is the basic categorization. Metals are used, polymers are used, resins are used, even the in the form of a powder, the gypsum is used. But again, for example, in the form of a liquid, the three-dimensional printing tool, that material is also used. That is, for example, in one of the technique I have already discussed in an inkjet printer, that liquid
Hmm.
polymer is used. So,
Correct.
liquid, metals, resins, polymers, so all these materials, they are already used, which are already used we are traditionally into the dentistry. These are not the newer material actually.
Okay,
Yeah,
thank you so much for sharing your presentation with us. We really appreciate it and we enjoy
thank
all
you.
the knowledge. Thank you.
Thank you.
Okay, our next poster presentation is Miss Isleni Salcedo, affiliation of Hospital Universitario of Caracas, who joined us from Venezuela. She will present the benefits of using Synchromats in the assessment of prescription of exercise in patient with cardiac patient device attending the cardiac rehabilitation program at the University Hospital of Caracas. Kindly join me. Welcome her. Mm, okay. Sorry, we are going to change. We're going to change for we're going to uh, present Mr. Narwan Darwish Al Navahin, presenting a speaker a perceived needs and acceptance of wireless vital sign monitoring among nursing staff in Oman. Please help me to welcome doctor, please.
Yes. Hello.
Hi,
Hi.
good morning.
Yes. Is my presentation clear for all?
Yes, it
Is my
is.
PowerPoint? Okay. Okay, good.
Thank you.
So, hello everyone. My name is Marwa Al-Nabhani. I'm from Oman. It's my pleasure to welcome you to this presentation. Today, I'm sharing the results of my study regarding wireless vital signs monitoring in Oman. We will specifically look at the needs of our nursing staff and how ready they are to accept this new technology into their clinical practice. So our journey today is divided into 4 main parts. We will start with the introduction and context to understand why this matters. Then we will look at the study design and participants. Third, I will share our findings on reliability and perceptions. And finally, we will conclude with the implications and recommendations for our healthcare system. In this part, we will explore the concepts behind wireless monitoring and why it's a clinical necessity for us here in Oman. So at the heart of this study is the goal of bridging technology and practice. We want to ensure that innovations are designed with input from the nurses on the front line. We focus on nursing staff acceptance because the best technology only works if the users are ready for it. Here in Oman, there is a clear clinical necessity to move beyond the limitations of wired monitors and introduce wireless patch innovation, which uses simple adhesive technology for real-time tracking. Why do we need to change? Currently, we face several hurdles. We rely on bulky wired devices with heavy hardware and messy electrodes. This leads to restricted patient mobility, where patients are stuck in bed and often suffer from skin irritation. Furthermore, it creates workflow inefficiencies. So nurses spend far too much time managing cables and entering data manually instead of focusing on the patient. So there is a significant gap in how we innovate. Most medical tools lack nurse-centric design. Additionally, there are research gaps in non-Western settings. In Oman specifically, there is a literature deficit, meaning we have very little published data on how wearable monitors would actually work in our specific clinical environments. So, sorry about it. I don't know what happened. So to address this, our study had 3 main objectives. We wanted to assess the need for these patches among nurses. We use the unified theory of acceptance and use of technology framework, which is a professional way to measure how people accept technology. Our ultimate goal was measuring the intention. So do our nurses actually plan to use this technology if we provide it? And here, I want to clarify the nature of this research. This is a study of a proposed innovation that I have developed. We are not testing on an existing product. Rather, we are measuring the clinical demand and staff readiness for this new concept. By gathering this data now, we can present a strong case to policymakers to support the transition from a design to a real-world medical tool. What is going on with this? Why it is going like this? Sorry about it. So for our methodology, we used a cross-sectional approach. Our research was conducted in a real-world clinical setting involving nursing professionals from both Samail Hospital and the Royal Hospital. which are both classified as secondary and tertiary national hospitals. We presented the concept of my innovative wireless monitor to 148 nurses. We wanted to know if this invention were available today, would it meet your needs? This data is the first step in improving to the Ministry of Health and policymakers that our frontline staff nurse is ready for this specific digital transformation. We were able to collect high quality responses, which provides us with a strong and representative samples to ensure that our results were not just observations, but scientifically valid. We processed all information through SPSS for rigorous data validation. This step was crucial to ensure that the patterns and conclusions we discussed today are backed by solid statistical evidence. Now, let's take a closer look at the professionals who took part in this study. Our participants represent a high educated group with nearly 65% holding a Bachelor of Science in Nursing and a notable percentage possessing postgraduate qualifications. This is a millennial cohort with an average age of 34, which tells us we are working with a staff that is naturally adaptable to digital change. Most of these nurses are in the prime of their careers, with 75% having between 2 and 15 years of experience. We also have broad representation from across the hospital, including the medical, surgical wards, and emergency department, and the ICU. So this diversity ensures our findings reflect the reality of various high-pressure clinical environments. So we tested our survey tools for reliability, and they scored very high. One key insight is that our nurses have distinct perceptions. They clearly separate how useful a tool is from how much effort it takes to use. This means they are thinking very critically about the technology. When we look at what nurses expect from this technology, their first priority is accuracy. They are very clear. For a wireless patch to be useful, it must provide data that is just as reliable as the traditional wired monitors we use today. There is a strong consensus among the staff that these devices aren't just nice to have. They represent a real clinical advantage. They see this technology as a necessary evolution to keep up with the demands of modern patient care. One of the most exciting findings in our study was the high score of patient mobilization. With a mean score of 4.35, nurses identified this as the single biggest benefit. In a transitional setup, wires keep patients stuck to their beds, which slows down their recovery. By removing those cables, we allow patients to move around safely while still being monitored. So nurses believe this will not only make the patients more comfortable, but will also help them recover and be discharged much faster. So there are, of course, some concerns. Nurses pointed to facilitating conditions like the need for strong hospital Wi-Fi. Many expressed technical anxiety regarding the pairing or connecting of devices. So we must address these concerns, as usability is often the biggest barrier to adoption. We also learned that social influence is a huge driver. Nurses are more likely to accept a new tool if they see their respected peers using it. For a successful strategic implementation, we must leverage these peer networks and find champions within the staff to lead the way. So implications and recommendations. To conclude, our study shows a strong readiness among Omani nurses. My main recommendations are, first, the design must be plug and play to make it easy to use. Second, we must empower senior nurses as champions to drive the adoption and help their colleagues feel comfortable with the change. Then integration with electronic health records. The batch should not be a standalone system. For long-term sustainability, data must flow directly into the hospital's existing medical record or similarly HR systems to eliminate manual charting entirely. Then another recommendation is the continuous digital competency training. So nursing education in Oman should incorporate digital health literacy into the standard curriculum. This ensures that new graduates enter the workforce already comfortable with the wearable monitoring and data interpretation. And finally, to develop a national cybersecurity guidelines for wearables. As this technology might expand in the Sultanate, if this innovation is adopted, the Ministry of Health should establish a standardized data governance framework to ensure patient vital signs data remains encrypted and secured compliantly. So finally, I would like to thank you all for your listening, and I would like to offer a special thanks to the Ministry of Health here in Oman and all the nursing staff who participated. Thank you for your attention. And if you have any queries, so please, you are most welcome.
Thank you so much for your presentation. Anybody have any questions?
Good morning, Miss Marwa. I will have a question. Thank you so much for the insightful presentation. We really enjoy. Did you face any challenges when you implement?
Actually, I didn't face any resistance from nurses, and there were no difficulties because usually we are facilitating our nurses, and we are continuously acknowledging our nurses about the importance of health innovation and the importance of connecting and bringing this kind of innovations into health system facility. So they were actually eager to have such study with them, and they were really very helpful to join the study.
Thank you so much. Thank you.
Most welcome.
Anybody have another question? Okay. I would like to ask, what are the wireless vital signs monitoring system and how are they used in a clinical settings?
Yes. So actually this, if I got your question clearly, actually this innovation, as I told, it is just a proposal. Like imagine in a handy vital signs monitor size with no wires, just it is a patch attached to the patient's hand only. So this is expected to be useful for the patients here in the clinical setting, because usually why this have come into our mind, because usually the patients are, some of them are restless, so they are not accepting to have a lot of wires and they will keep on pulling them out. So we were we had like a need to think widely and to think deeply into bringing out such innovation into the healthcare system. So now we have got like an intellectual property from the Ministry of Commerce and Investment here in Oman, along with the help of the Ministry of Health. And they are actually welcoming such innovations as long as it is beneficial for the patients. Hopefully, they will adopt this innovation.
Thank you so much.
You're most
Okay, anybody has any other question? Okay, we are going to take our 15 minutes coffee break. We are gonna be here in 15 minutes, okay? Thank you. Okay, everyone, we are gonna continue with our meeting. After the coffee break, our next speaker is Mr. Christina Amores Hudson, Director of Nursing Emergency Care Center. She will present on a patient experience reminding nurse-led triage, resign, and flow optimization. Kindly join me in welcome her.
Hi, good morning. I requested for someone to allow me to share my screen so I can share my presentation. There we go. Okay, just confirming that everyone can see this okay?
Yes, go ahead.
Okay,
Yeah.
perfect. Thank you, Claudia. So good morning. My name is Chris Amores Hudson. I am the Director of Nursing for the Emergency Department here at one of the National Guard sites in Riyadh, Saudi Arabia. I work under the Ministry of National Guard Health Affairs. It is my pleasure to be with you this morning. We're going to be talking about a project that is near and dear to my heart. This is something that we've undertaken here in the Emergency Department over the course of the past year. And it is in regards to a complete nursing-led redesign and flow optimization for nurse-led triage. So let's get right into it because I think I only have 20 minutes, I think. Okay, so this is how we started. What were we facing? We were dealing with 500 plus patient visits per day in a level 1 trauma center. We had massive overcrowding happening, extremely long wait times with high uh, left without being seen rates, which of course ultimately leads to very poor patient satisfaction, nurse burnout, high stress levels. We were struggling with retention. On average, we see anywhere from 180,000 to 200,000 patients a year, which equates to anywhere from 500 to 800 patients every 24 hours. So you can imagine the volumes coming through our department were quite high. We had significant challenges. So why do we reimagine triage? Well, it's about patient safety, it's about enhanced patient flow and efficiencies, and ultimately about staff experience. But I think what's most important is that throughout this process, we kept our patients at the center of everything that we were doing. So some of our drivers for change, we looked at our patient experience scores, obviously, and we had some of the probably lowest performing patient experience scores within National Guard out of our multiple sites. I think we're up to 7 sites now. So obviously very concerning. We had a need for nursing-led innovation in order to engage and empower our workforce. And then obviously we wanted to drive patient-centered care as a benchmark for quality. So increasing patient volume seasonally and day to day, which was population growth and adds to the trauma burden. And essentially what that means is that, certainly during, we have slow periods, during the summer, that wasn't the challenge, but as soon as the schools come back in, we have an influx of high volume, high trauma, high patient need access starting usually, as soon as that lets out. Eid, Ramadan, same thing. So we were challenged in, peaks and valleys. We wanted to make sure that one of our drivers were changed was also that our actions were firmly rooted in the aligning with the Saudi Vision 2030 through healthcare transformation. So our current state looks like if you were a patient that came into our department, you'd have your pre-screening done as soon as you walked into the department. You'd have then nurse-led assessment done at triage. We had multiple entry points for patient flow, which was also one of our biggest challenges. And certainly because of the size of our department, we have 171 beds in this emergency department. So essentially, we're almost like a small standalone hospital. So when you have multiple entry points for patient flow, you can well imagine how that also contributes to concerns for patient safety. We triage based on a Canadian triage acuity scale, which is known as CTAS. It's actually used across the kingdom here. And we were having incomplete triage being done simply because the environment itself didn't allow for proper triaging. We had batching of patients, which is, if you know anything about lean methodology, that is the number one issue in terms of waste and inefficiency. So that was a huge challenge for us. We had multi-directional patient flow. We were going backwards in our patient flow at times. We were moving patients numerous times from one place to another. And research shows that every time you have to move a patient, you actually contribute to causing potential risk for mistakes, errors, harm to patients. So that was a huge concern for us. And we had no identified space for safe ambulance triage. So some of our limitations, we had bottlenecks at entry points. We had poor design for triage assessment space. We had no controlled access into the ED, which was a huge safety concern for us. And we had no defined waiting room, which was, as you can imagine, an emergency department not having a waiting room. Patients and their families needed to go somewhere. So it was just adding to the sense of chaos that existed in the department. So it really had this first come, first serve perception. So we stepped back as a leadership team and it was kind of like, where do we start? And the diagram that you see here is actually how it all began. We started with a complete value stream mapping process so that we could really
Excuse
look
me.
at.
We are not able to see we are in the first slide. We cannot see your diagram.
You haven't
Okay.
seen any of my slides?
No, now it's moving.
Okay, I'm not sure what to do because I'm sharing my presentation.
Yeah, now
So
it's moving. Is drivers of change, patient experience score.
you should be able to see, I'm on slide 5, which is where do we start?
I just see this. Okay, current state. Now it's moving.
Do you see the slide, where do we start? I'm on
No,
slide 5.
now it's moving. No, it's good.
Now it's good. So now you can see this slide that says, where do we start? Can you see my current slide that says, where do we start?
Yeah, just continue next.
Okay. So as I
Thank
was saying, with this, you can see in the diagram that there's a picture of value stream mapping, and this was a process. This value stream mapping exercise, which you can see through the boxes and arrows, and we actually started with that because we needed to define what was our current state. You can't move forward unless you clearly understand what does my current state look like in order to get to your future state. So it was a very messy exercise, to be honest, and it took us about 5 hours. I've been doing lean methodology and change process for many, many years. This is probably one of the most challenging that I have personally experienced. So we'll go on to the next slide. So this is a redesign framework. I'm hoping you can see this. So when we looked at what kind of framework we wanted to use, I think it was important for us to sort of maintain a foundation together so we didn't stray too far from our purpose. So the principles for guiding change, flow before wait, like moving patients forward instead of all the bottlenecks and the moving multiple patients that we had numerous times. Right care, right place, right time. That was an underlying philosophy that we applied from the moment that the patient walked through the door. The concept was for the nursing staff to make sure that they were always thinking from, pre-screening to triage, like, I need to get this patient into the right bed the first time. That's how we tried to frame it. Next thing we did was we really empowered nurses as decision makers. So we started using the language. This was even supported by the chairman of the emergency department himself. And the whole idea was he wanted explicitly, he said, Chris, I will support you. The nurses need to own this. So we really went from a place of this is nursing driven patient flow. We really wanted to empower the nurses in that respect. And they really bought into this, and it has been instrumental in our process. We're about 6 months into this now. So the final thing was, of course, embedding technology and data analytics, because you need to be able to monitor, measure, and evaluate the effectiveness. But pulling some data for us was a bit of a challenge because of the system we use. So we had to work very closely with our quality team, our data IT team, in order to make sure that we would be able to pull, our left without being seen, the point of, from the tracking the patient's journey from the point of registration, time to first physician assessment, time to first nurse assessment. So that was extremely important because, as you know, data speaks volumes, and that's how you build credibility with any change process. So initiating the redesign, we had to look at the physical. First of all, we had to start off with a complete physical redesign of the triage area. And this was one of the most challenging things because it required buy-in from very high-level executive. But to our surprise, because we were able to really impress on them that this was going to be the way in which we directly support enhanced patient experience. And that was a key driver strategically. Both the COO and the CEO bought into it, and immediately we had the support that we needed. So within 4 days, we actually started a renovation project in our triage area. Again, nursing voices were heard and redesigned as part of this process. The other thing is that we had to support a more complete triage assessment. And the way that we did that was through this redesign so that the nurses could do a full-on a proper triage assessment because we needed vitals. We really needed to be able to assign the correct triage level from that point of entry so we could get them into the right bed. We needed to enhance patient-centered care, and that was all basically embedded in the process. We wanted the patient to feel like we've heard you, and we're going to take care of you by getting you into the care area most desired. The other thing is that we needed to put efforts to ensure that we had standardized application of CTAS. So what we realized very quickly through auditing is that we had a nursing workforce that did not have standardized education when it came to CTAS. So we immediately undertook a very robust education program in terms of creating a defined CTAS workshop so we could standardize the approach to triage as well. The other thing is, so that meant that when the patient presented, it was by clinical urgency so that we had confidence that our nursing staff were applying the appropriate CTAS level from the beginning. We also had to have a standardized approach for all staff, and that was to make sure that the CTAS, because it's the CTAS that was getting that patient into the right area the first time to get the care that they needed within that designated time frame. Urgent patients require a physician assessment within 30 minutes. Well, we were never meeting that target because we just had such poor patient flow. We never had beds to put patients in. So we had numerous key targets and KPIs that we had to meet throughout this process as well. So when we look at the nurse-led triage redesign model, what we did was we initiated a split flow. So we designed a complete rapid assessment zone, and then we streamlined care pathways from all points into the ED. So we had 2 points of triage set up. One was at the ambulance checkpoint that we had created that came into our trauma and resuscitation zone, and the other was through the front doors of the hospital. So we were really focused on making sure that we were dealing with our high acuity patients appropriately so that they were getting the immediate care, and then those moderate acuity, those were nurse initiated protocols and then transfer into the correct zone. So a CTAS level 3, for example, could be triaged by the nurse and directed right into the care area that they needed. So we could ensure that the patients were getting that assessment, that first physician assessment according to our KPIs and CTAS guidelines. Then we looked at our more low acuity patients. So those are like CTAS level 4s and 5s, our less urgent and non-urgents. And those we created. So we actually created a beautiful fast track area. We have 12 designated beds in that area, along with we set up a phlebotomy area, we set up designated ECGs. Like we really wanted to have this nurse-driven care so that we could have these patients don't require physician assessment for the first 60 minutes it can take. So we wanted to still at least get that patient's care path started. So we worked that into our space as well. And then finally, and we've entered into phase 2, which is bedside registration to reduce that front desk bottleneck. This is a very new concept for this for our hospital. So we're having to work at things slowly to make sure that we've got buy-in and engagement, because you can also have change fatigue. So we're being careful to try and avoid that. So we looked at some of our flow optimization strategies. We had team-based nursing care in triage, our rapid assessment zone, and our fast track. So we had RNs plus support staff. So that looked like we have PCTs, patient care technicians, and we have care assistants as a second pair of hands to nursing. We obviously implemented point of care testing to allow for rapid decision making. That included not just glucose, but also we have Gen X machines, so we can do COVID swabs. So our nursing team direct that. We can have results in under 30 minutes, so we can safely place our patients. We have real-time dashboards for tracking waiting times inside and outside of the ED. We're initiating phase 2 of that, which means that we're going to look at how it is we can post our wait times through our hospital app as well, because we also want our patients to know that this isn't your only choice for healthcare. You might want to consider primary healthcare. You know, is it really urgent? Do you absolutely need this level of care? So then phase 2 is that the fast track areas will include advanced practice nurses. That's going to take time, but we are working on that. That's just a new model of care here in Saudi. So, but we're actively engaged in working on that. We have nursing-led patient flow. So what we've been aiming to do, we call it pull to full. So we want the nurses, again, because it's about nursing-driven patient flow. So the physicians know that the nurses are always going to be filling the bed. So as soon as they see, assess, treat, and discharge a patient, that patient is gone. Immediately, it is the nurse's responsibility to get another patient in that bed. Prior to this, it was actually physicians dictating when the nurse was allowed to bring in another patient. So you can imagine the inefficiency that was created by that. And we also we created a disposition waiting room. And that's a virtual waiting room. And so basically what that is it means that if we have a patient in our fast track area, for example, and they're just simply waiting on lab results, or they're waiting on an ultrasound report to come back, and they're stable and comfortable enough, we move them back out to the waiting room, but we don't lose our patients. We keep them in our disposition waiting room virtually. And we have 2 nurses that are assigned to our waiting room reception desk, and their job is constant reassessment of patients, and also looking and constantly monitoring when are the labs coming back in, when are ultrasound reports, whatever, CT reports, when have they come in. We then bring that patient back into a room in fast track, so that physician can then discuss the results with them and then discharge them safely home. Or to a consult for another consult. What that has done is it just has freed up our beds, so we're constantly working on turning over those beds, so we don't have patients sitting in beds that don't need them. And that was how we were working towards enhanced patient experience. So what was the role of emergency nurses through this? Obviously, a ton of pressure, to be very honest, and we spent a great deal of time really engaging with our frontline staff, really building up their confidence in this, having them as the gatekeepers of flow and safety. It's not perfect. We work on it every day, but it is so much better. So much better, in fact, that there's our staff satisfaction scores have increased by 12% based on our recent survey from the previous survey that was done. And also our patient experience scores have indeed increased by 9%, which is just a tremendous improvement for us. We have advanced assessments and critical thinking happening, where the nursing staff are adhering to more standardized practices at triage, and we've now put 80% of our staff through a standardized triage course that we created here. And we actually audit, routinely we audit anywhere from 100 to 200 patient charts a month to make sure that we're still, it's a small sample size compared to our volumes, but it's what we're capable of doing right now. But we wanted a means of being able to monitor our success with, our standardized triage to make sure that nurses are actually assigning appropriate triage levels, and it is what's required. We're leading rapid interventions and decompression of care areas. That happens every day. It's nothing for us to sit with 30 to 40, 45 patient admissions sitting in our ED. So, when they're taking up a third of our beds, it's important that we're constantly looking at how we can assess, reassess, and discharge so we can keep our emergency patient movement going at least. And then obviously advocating for patient experience. We're very fortunate to have patient experience officers within our department. And with a little help and a little education, they have become a tremendous support to the ED staff in this respect, as opposed to before. It was quite abrasive. It was a very abrasive relationship. And there's great collaboration now with physicians for expedited care. That's been a part of probably one of the most positive outcomes of this process, to be honest. So what have we achieved? We've decreased our waiting times, our door to triage, our triage to first nursing assessment, and our time to ED physician assessment in some of those areas. So we have a 6-minute international best practice says that patients should be receive their triage within that 6-minute period of arriving into the ED. And I'm very, very grateful and very pleased to say that our team has taken our initial time from 9 minutes to we've just now hit that 6-minute target. So that's been a very positive improvement for us in the last six months. Our time to ED first physician assessment obviously has also seen significant improvement. We have a decreased length of stay in fast track. We have a less than about 2.5 hours, which is our target based on the total volume of the number of C-test level 4 and 5 patients that we put through. So this has also been a really positive improvement because prior to this, we could have C-test level 4 and 5 patients sit here for easily 6 hours, and those should be your quick turnover patients. So this has been a positive, really positive change. We've decreased our left without being seen. I think our last review of our last quarter data was we've improved overall by about 6%. We've increased patient throughput and satisfaction tremendously. When you compare patient experience scores from this year to last year, we've seen, as I mentioned, we had a 9% overall improvement in a very short period of time, which is in my experience in 21 years of nursing leadership has just been unheard of. We've also increased nurse autonomy and engagement. It has been so wonderful to watch this happen, to see our nursing workforce really grow into this and see the confidence, their confidence level, and really notice such a positive change between that nurse-physician relationship. The staff are telling me it hasn't felt like this for many years, and so it's been great to see that flourish. And also physician and resident satisfaction. The chairman himself said to me that they were really struggling we're a huge teaching hospital. So for us, having residents want to come and do their time in our departments is really important. And up until recently, the feedback has been very negative. Prior to this past 9-10 months, we have residents who have not wanted to come here. And now the ED chairman has shared with me that now residents are, wanting to be here. They're excited. They can't believe the difference and the change in this department from when they came through as juniors. So that's also been a really, really wonderful change. It's completely changing our workplace culture, to be honest. We have much stronger alignment with quality and safety standards, and this was absolutely huge for us. So patient experience reimagined. This is how we again, this was the language that we were using with everyone. We have a faster, smoother, and timelier entry into care, which was extremely important. And that was a directive that came from the CEO himself with clear expectations of what he expected to see change. Then been amazing to see. And our patients have said themselves, because we have our managers doing leader rounding, even in the waiting room, the patients are now saying that they feel more seen, they feel heard, they feel like somebody cares, they're feeling more prioritized. So that's all been extremely positive feedback. Some of the challenges and the lessons learned, this is a no-brainer. This happens in any change project. I think any one of us can, certainly relate to this. There's obvious resistance to change. And that's, because of the staff adaptation. That was not just on the nursing side. That was across every discipline in our department. So we had a number of challenges that we had to work through, but essentially that was just presence. It just required leadership presence and visibility. That was the most important thing. Balancing speed with safety, people were everything was a tick box. Everything was just like go, go, go. And the most important thing is slow down, make sure that your work is quality and that you're providing the best possible patient experience. So we gave them permission to do that. With the need for continuous data monitoring, as I mentioned, we really struggled with data in the beginning, and now we have great partnership with our quality person that works here directly in our department we've worked together to create dashboards. We're presenting data monthly at our ED, our medical management department meetings. And we have also the importance of leadership support and training across all disciplines. It's always interesting when you go through change like this, you really start to see, some of the areas within our own leadership team where we really we had to step up and support them in terms of being able to have crucial conversations, deal with conflict and resistance, and support, nurses through change. What are the phases of change? What does that look like? There's a whole lot of education that had to go on behind the scenes in order to keep the momentum with this going. But consistency and momentum beyond the first days is just so, so important. We're always excited when we get started in projects, but it's actually how do you maintain that as you carry on through some of your, quality and safety initiatives. So you never ever take your eye off that long-term goal. So for me, it was myself, I held myself accountable to it. I held my managers accountable to it. Even the physicians themselves, like we have to be present. We all have to own it. And we need to, when issues arise, let's try and fix what we can fix. And then, deal with what we can't fix in the immediate moment. Like, let's not lose sight of it. So that was really, really key, actually, not to get complacent. And the other thing you'll notice, one of my last comments there was celebrate something every day, because people are tired. They're tired because they're doing their best. This is a massive, massive change, initiative. And it's extremely important to make sure, no matter what, even the small things, you celebrate something or you recognize someone, whether it's nurse, physician, or whatever. That was so important for us to keep the momentum going through this process. So our future directions, we've got initiation of care pathways from the point of triage. We're actively working on that right now because we really want standardized, I'm originally from Canada. And for us, our nurses have autonomy in practice because the physicians themselves have worked with nursing leadership to create these, we call them standing orders that can actually be started right from the point of triage, and it expedites the patient care. So that's something that we're working on in phase 3 of this project. We're also looking at AI and predictive analytics in triage. We have a huge project that we just initiated. I'm super excited about. So I can't say a whole lot about that, but we're really working on a massive project for this right now. Implementation of nurse practitioner roles. There's a little bit of resistance to that because it's a brand new concept here in Saudi. But we're working closely trying to come up with scopes of practice and really figure out how that role can fit into our department. And do we have experienced nurse practitioners here in the kingdom, or do we need to look internationally? But it's also getting people to understand how the nurse practitioner role aligns with caring for, say, example, CTAS level 4, those less urgent or non-urgent patients. Development and implementation of live dashboard. I've already talked about that. We're actively working on the development of that, well into that phase. We've been using a couple of drafts and we're tweaking as we go. Ongoing staff education on flow sciences. This has been so, so important. Your staff have to understand the why. And if they don't understand this process, I'm using things like value stream mapping, lean methodology. You have to bring it down to that level. And basically what I do is I help them to understand the why. And I always tell them my job is to help make your job easier. And because we're all responsible for good, high quality patient care. So we never lose sight of that. We're really actively working on embedding that into education. We're building in, for at all levels with my leaders, with my educators, and with my frontline staff, providing educational opportunities for change, the processes, the principles of change, like change management, transformation, using lean methodology, and taking some of the concepts, for example, from, what I learned when I was doing my yellow belt, and really helping staff learn in that respect. So some of our key takeaways where nurse-led triage redesign is incredibly transformative. And I think we were very, very fortunate here because we had complete buy-in and support from our medical leadership, which was essential to make this a success. We had flow optimization that directly improves patient safety and satisfaction. So it made it easier to get buy-in from some resistors to change, let's just call them that. We had nurses as leaders in healthcare redesign, which is it's essential. It's absolutely essential. Engaging from frontline staff in patient flow transformation means you have more buy-in, it creates an empowered workforce, and it also creates positive staff satisfaction, which, as you know, the research shows ultimately that just enhances your patient experience tenfold. We had sustainable change, which requires vision, leadership, teamwork, and constant monitoring and evaluation. Like, we never take our eye off this. We're more than 6 months into it now. And we are constantly looking at in fact, I was just at a meeting last week and I'm like, okay, this isn't working. We now need to come back and adjust this flow. We need to adjust this. We're getting bottlenecks here. So we're constantly looking, evaluating, monitoring, and then redeploying new processes. And just don't let up, even when things feel hard. Just don't give up, because even the smallest changes have a big impact. So I just close with, reimagining the patient experience starts with nursing leadership. And truthfully, I do have to say, in my case, I also am very, very fortunate here to have had great physician leadership and great physician buy-in, because without it, we wouldn't have been successful with this. So that is the end of my presentation. I'm not sure if anybody has any questions they may like to ask.
Okay, if nobody has a question, I have a question for you. I would like to know, how does triage redesign help in optimizing patient flow in healthcare settings? I'm asking this question because I'm working in a community health center, and I know that we have a lot of patients that we need to give it the best. But as you mentioned, it's a little bit challenge to
Yeah.
to achieve.
So I think first and foremost, like, I think everything that we do, because when you keep the patient at the center of everything you do, and it's at the center of your decision making, it makes it easier to get buy-in from higher level executives. So if you can bring everything back to, look, if we don't fix this, this is the impact it's going to continue to have on patient care, patient experience, which are all negatives, right? If you're not making the right moves. And if you don't get that leadership buy-in, that senior leadership buy-in, it can be very problematic. But I think most importantly, when I started this, I was very new to this team. I literally had only been here 3 months, but I've worked in the Middle East for 12 years. I've been a nurse for 31 years now. I've been in leadership for 21 years. You just know, we know that some of the basic principles. And what I had to do was I just took my team back, because it felt very, very overwhelming and daunting to them. Like, if you could see the lineups of patients, like, imagine 600 patients in 24 hours coming through your department, right? The influx of that patient volume, the staff were so completely overwhelmed. The physicians weren't supporting them. None of the other support, the patient ER coordinators, nobody was supporting them. And I said, let's take a step back and let's actually we can't bite off the whole elephant, but if we could change one thing today, what would that be? So engaging the frontline nurse and managers and frontline nursing staff right away. And they had great solutions. And that's kind of what I realized is that they were so busy working in the patient flow, they actually didn't know what they needed. So it wasn't until I literally covered the wall in the hallway outside my office. I'm a very visual person, so I'm all about, like, if you have to, I didn't have a smart board, so cover the wall in chart paper, get your markers and sticky paper out, sticky notes out, and literally map it out. The patient comes through the ED. This is the first thing. What's the next thing? What's the next thing? And that's why it took so long. And even they were shocked. And some of them have worked here for 20 plus years, and they had no idea that this was the actual flow. They were like, no wonder we're suffering and struggling so much. No wonder our patients are so unhappy. So by engaging them in that process right from the very beginning, I can guarantee you it's what led our success with this initiative, because there was very early buy-in, because they said, yeah, we need to change this. We have to fix this. So I think I hope that answered your question, but I just said we're always going to keep the patient in the center of everything we do. And in the process, we're going to engage the staff as much as possible in order to support the change that needs to be made. And I think one other thing, and I didn't mention this, but like one of the tactics we used was, wait, I don't have all the answers and they don't have all the answers. And sometimes you have to try things to know if it's going to work. So for example, I bought clipboards and I put 2 clipboards at every single nursing station. And on the one clipboard, it said, what worked really well for you today? And on the other clipboard, it said, what were your challenges today? And so we made a commitment that at the end of every morning, we would review we had 12-hour shifts. So we would review everything. And people are like, Chris, that's so old school paper. And, I said, yeah, it is. Because you know what? It's there. It's on the desk. So if you are running, you still have time to quickly stop and write something on a clipboard. And what it also did, and I said, we don't need to hear just from nurses. I want to hear from the physicians. I want to hear from the social workers. I want to hear from everybody. How is this, the PCTs, the care assistants? So everybody felt free to walk up and write something on the clipboard. And so we made a commitment as a leadership team that we would review those every 24 hours and come back. We'd put fresh sheets, and then we would close the gaps on anything we could fix immediately.
Thank you so much for your answers. Anybody have any other questions? Okay, I think that we conclude the session for today. Thank you to all the speakers and delegates. We also want to share with you the upcoming conference. Let me just put it here. If you guys want to join us for the next conference, you have the QR codes here. You can scan and you can register for the next one. Thank you so much.